The ARC in HealthMatters Brain Health and Trauma Informed Care 2023 webinar series. Today's webinar is on trauma and ableism as a social determinant of health for people with intellectual and developmental disability. The webinar, Healthy Brain webinar series is presented by the HealthMatters program. We're located at the University of Illinois, Chicago, in partnership with National Task Group on Intellectual Disabilities and Dementia Practice and the ARC of US. We are funded by the Centers for Disease Control and Prevention through the Healthy Brain Initiative Award. And contents are solely the responsibility of the webinar presenters and do not represent the official views of the CDC. In a couple of housekeeping for today, CEU's continuing education credits are not offered for these webinars. Each live webinar will be recorded and we will make it available, the recording, the PowerPoint deck, and any resources that we talk about today will be available on YouTube channel. You will be emailed once we post this, and it's usually within 7 days of the webinar, of the live webinar. And then please use chat box for comments and questions. We will have about 10 to 15 minutes after the presentation for question and answer. Feel free to start asking questions. I will just compile them and ask them of the presenters at the end of the presentation. We have 3 presenters today. I will let each presenter introduce themselves when the time comes, just to kind of save time, since I really want them to talk to you. And the overview of today's webinar is we will examine ableism as a social determinant of health. We will provide a practical how-to list when addressing discrimination of people with intellectual disability in healthcare setting, and highlight progress in moving to supported decision-making strategies. Just to kind of ground us in sort of some definitions and talking about ableism and social determinants of health and brain health. When we talk about ableism, we really, what we mean about that with that word is that it's the discrimination of and social prejudice against people with disabilities that's based on the belief that typical abilities are superior. And at its core, ableism is rooted in its assumption that disabled people require fixing and defines people by their disability. Similarly to racism and sexism, ableism classifies entire groups of people as less than and includes harmful stereotypes, misconceptions, and generalizations of people with disabilities. And then in regards to trauma as a social determinant of health. Experiencing trauma, including ableism and disability bias, can be considered a social determinant of health. Studies are increasingly documenting a connection between experiencing traumatic events and physical health outcomes. When you're looking at the research on the intersection of violence and disability, it is fairly limited at this point. However, some statistics considering in 2015, disabled people were 2.5 times more likely than non-disabled people to experience violent victimization. Serious violent crimes such as sexual assault, aggravated assault, and robbery were even more disproportionate, more than 3 times as likely to impact people with disabilities. People with cognitive disabilities had the highest rate of violent victimization. In 19% of rapes or sexual assaults against persons with disabilities were reported to police, compared to 36% of those against people without disabilities. More than 90% of people with developmental disabilities will experience sexual abuse in their lives, and 49% will experience this abuse at least 10 times. Impact of social determinants of health accounts for about 30 to 55% of health outcomes in general population. We do not know this data for people with intellectual disabilities. And really thinking about this, this presentation for people with intellectual disability, there's a need to move beyond the medical model to include social determinants of health as a standard of care to improve equity in healthcare and health outcomes for people with intellectual disability. All right, Leanne, take it away.
Thank you so much, Jasmina, for that great introduction. And I think it's important that in this series, we do provide that foundational knowledge. There may be some key things that are repeated in the series, and that's because we want to make sure everyone's getting the same basic knowledge around some of these key concepts that we're talking about in the series. So thank you so much for providing that. If you didn't hear the first webinar, my name's Leanne Davis, and I'm the Senior Director for the ARC's National Center on Criminal Justice and Disability. I've been working at the ARC at the intersection of people with IDD involved in the criminal justice or criminal legal system for 27 years. This has been a huge passion of mine since really finding out just how often people with disabilities remained unseen in the criminal legal system, and the same can hold true within healthcare as well. So there are many overlaps in these issues, and a key piece of what the National Center does is look at both sides of the issues of if someone is involved in the criminal system. For example, we discovered early on just how often people with IDD were traumatized, and how our systems within our criminal, legal, or justice system actually able to respond to that. Our rape crisis center is accessible. Are people believed when they try to talk about trauma? So all of these issues really came together in us looking for a way to address this more holistically. I gave some just basic facts about the center on the slide. I think the key point is just the mission that we're really advocating at that intersection where we're trying to reform systems, and this can include the healthcare system, while we're also advancing the rights of people with disabilities. And you will hear from Dr. Kripke later on the issue of supported decision-making and why that's so important and how that ties into this work. I just wanted to mention too some of the things that we are doing at the National Center. One of the things that I wanted to highlight on this webinar is that we are providing nationwide training and technical assistance. And we have what's called our Pathways to Justice training that has a module specific to people who are providing specific support to those who are victims of crime. So anyone who experiences any time of victimization, we have a module for victim service providers. And this can include folks in healthcare as well. So this training is really meant to not only provide kind of key foundational concepts of understanding how to ensure that if you have stereotypes about people with disabilities, how do you understand what you bring to the table when you're trying to support people with disabilities who are victims of crime or who are traumatized. Not only providing that foundational information for them, but we also create what's called a disability response team so that there's a holistic approach to addressing these issues, not just from victim service providers, but from attorneys and from police, those in the community who are involved in addressing anytime someone is traumatized or victimized. So these are key pieces to what we are hoping to do with the center, is to break down silos and really bring communities together around these issues. Now, we did mention too, I think that we need to advance the slide, Yasmina. Sorry about that. I didn't realize it had not advanced. And you can go to the next slide. So we did mention too in the last webinar about the trauma definition that we're using from SAMHSA. So it is provided here on your slide. we had talked about the different types of trauma that people with disabilities may experience. And I know Yasmina mentioned some of the data. We had found too that there was data from the Bureau of Justice Statistics that found that people with intellectual and developmental disabilities specifically were 7 times more likely to experience some type of sexual violence compared to those without IDD. And that's the reason why at the National Center, we decided to really focus on sexual violence as a key piece where we see ableism really impacting society's ability to look more deeply at this issue. We also had heard from survivors of sexual violence on the last webinar. We heard from Patty Katari, who revealed that her trauma of sexual assault was explained away as being part of her disability. The response to her assault was to be medicated, isolated, and sent to a psychiatric group home without anyone asking about what actually happened to get to the bottom of the trauma. So she was really more seen as a psychiatric patient and less as a trauma survivor. The focus was more on her disability and less on the trauma. And so the goal in what she was talking about is for her trauma to be seen, and that she could equally be seen as needing support in that area. So her story really reminds us that sexual trauma, whether it occurs to someone with or without disabilities, has a direct link to brain health, and it can include all of the symptoms that you see on this slide. We talked about behavioral effects, physical, sleeping issues, dementia. These are just some examples of how it can impact individuals. And also, we decided to focus on sexuality issues specifically at the National Center because it is really core to a person's identity and too often overlooked. We actually are denying people their humanity if we're not raising the issues around sexuality. And I wanted to share a quote, and this is paraphrased. It's a quote from Barbara Faye Waxman, who was a well-known and respected disability advocate, author, and educator. She said that no group in this country faces the sort of sexual and reproductive restrictions that people with disabilities do. We are frequently prevented from marrying, bearing or rearing children, learning about sexuality, having sexual relationships, and having access to sexual literature. This has led to discriminatory social policies and is keeping us in a state of sexual self-hate. So looking at sexuality in particular and sexual violence, we can really see how those ableistic attitudes can impact how society views people with disabilities, and how that really has such an impact on the ability of somebody to even get educated about their own sexuality, about knowing what's safe and unsafe, about knowing what to do if they're traumatized in any way. So I think it's important that we keep in mind how important it is to provide education for people with disabilities around these types of issues. And next slide, please. And that's why we have through the center the Talk About Sexual Violence project. The strongest tool that we really have to fight against this type of discrimination and the countless other ways that people with disabilities are discriminated against in healthcare and in other areas of their lives is to support the work of survivor leaders who do this work across the country. That is really the key mission of the Talk About Sexual Violence project that we are doing with Kecia Weller, who you're going to hear from today. She's bringing her own voice to this issue, her own story, her own lived experience, and it's really helping to shed light on the dangers of ableism, those attitudes that healthcare providers can often have, and how we can easily stereotype and make assumptions about people with disabilities. It's so important that we understand the dangers of that, and stories like Kecia's really help to bring an honest approach to the discussion. Also, the project is looking to provide practical tools that address these stereotypes, like short videos, and it also comes with charts, scripts, and other tools to make it as easy as possible for healthcare providers to feel confident in talking about sexual violence with their patients with intellectual and developmental disabilities. And we do have a QR code here on the slide if you want to use that to look up more about the project. Next slide, please. And during the last webinar, we shared the slide about the core values of the project is that people with disabilities will be listened to and that they would be believed. And I wanted to go into a little bit more detail about James's story. He's a national leader in the field of sexual violence prevention among people with intellectual disability. He has been a passionate advocate in the world of self-advocacy for over 3 decades, but it wasn't until about 7 years ago that he decided to really start doing more in the area of sexual violence as a survivor himself. And what has been really concerning about his story, and not different from the statistics that we heard earlier, is that he has experienced at least sexual assault at least 4 times in his life in different ways. And the problem is he was not believed. Even when he went to his doctor, he was dismissed. He was afraid to tell anyone because of this experience. He was afraid if he told anyone about future experiences that he still would not be believed. And then when it finally happened to him the 4th time in his own apartment, he was able to get help and call the police. But it took a number of times for him to even feel like he could be heard, believed, and get the support he needed. So a key message that we really want to bring through this project and to the webinar today is that the burden to get the healing from trauma is often put on the victim themselves, and that they have to keep searching for someone who will finally hear them and believe them. And we know that this has to change, which is a key message that Kecia will be bringing here in a few minutes as well. And speaking of Kecia and her work and her story, for this series of this webinar series, we're using a very specific case scenario, the one that you see. Oh, sorry, next slide. The one that you see on your screen now. This is the case scenario that Kecia meets with her doctor. Thank you. And so we're using this to sort of be a thread throughout the webinar series, because we can look at her story from many different angles and learn different things and different lessons from what she experienced. Today, we're going to be considering her lived experience through the lens of how ableism, or wrong stereotypes of people with disabilities, can be a barrier to accessing much needed services as a trauma survivor. Now, if you are new to the webinar series and you have not had a chance to watch the short video, which is here on your screen, please take a minute to do that after the webinar today. And please share this with others in your network, healthcare providers, disability advocates, so that they can share this as well. And if possible, Yasmina, if you can put that link in the chat so that people can get to it quickly and easily. The slide here lists concrete ways that healthcare providers can provide a trauma-informed response to someone with IDD. So for example, the nurse and the doctor having gentle tones to their voices, being genuinely concerned about Kecia when they see symptoms of abuse, physical abuse. And so I think one of the questions we want to ask for this particular webinar is, how could these responses look different if a healthcare provider made inaccurate assumptions about Kecia? If they had an ableist attitude, they may not have believed Kecia. For example, in bullet number 4, we see that the doctor used a picture chart to help Kecia articulate what happened to her. But if there are stereotypes about people with disabilities, then the doctor may not even take that questioning further and ask questions to her about what happened. This really ties into what Yasmina shared earlier about social determinants of health. Too often, ableism can create barriers to people with disabilities accessing mental health care, for example, or other forms of health care that they need as trauma survivors. Sometimes people don't get recommended for healthcare services as trauma survivors because healthcare providers may not realize that trauma impacts people with IDD just as much as other individuals. So for people with IDD, we really do need to move beyond a medical model and look at the social determinants of care as a standard of care to improve equity in healthcare and health outcomes. So now I'm going to turn it over to Yasmina to introduce our next speaker, Dr. Clarissa Kripke.
Thanks, Leanne. I wanted to welcome Dr. Clarissa Kripke. She's the director of the Developmental Primary Care at the University of California, San Francisco, Family and Community Medicine. Dr. Kripke, please, you can add anything else that you would like.
Thank you. Thank you so much for having me. This is such an important topic and such an important framing of the issue. So I really appreciate that. The mission of the Office of Developmental Primary Care is to build the capacity of the healthcare system to serve transition age youth and adults with developmental disabilities. And sexual health is important for everyone, including people with disabilities, as we've talked about. When I went to give this talk, I consulted a number of my disabled friends to ask them what I should talk about with regard to trauma and abuse. And to the person, they all started talking about experiences with professionals and therapeutic services. That wasn't what I expected, but I understand where it comes from. Communication barriers between professionals and people with psychiatric and developmental disabilities can lead to mistreatment. A basic principle of disability rights is nothing about us without us. People with disabilities need to be at the table when anything that impacts us is being discussed. People with disabilities need to be a part of the solution, to lead policy discussions, and to be full partners in care. And I'm glad that those principles are being demonstrated in today's talk. So let me give you some examples of how professionals and therapeutic services contribute to trauma. A nonverbal patient was walking up to people and punching them in the chest. This was his presentation of heart pain. Instead of getting a workup for heart disease, he got medicated for aggressive behavior. A nonverbal patient couldn't be discharged from the hospital because he wasn't eating. The reason he wasn't eating is that he needs someone to cut up his food, but nobody took a history of his functional needs, so a feeding tube was placed instead. A woman with an intellectual disability who uses a wheelchair nearly died of cervical cancer because her doctor didn't ask about sex. Her doctor assumed she didn't need a pap smear. A child is being sexually abused. Her communication device has vocabulary to request food and games, but no vocabulary to protest, to set boundaries, or to communicate that she is being mistreated. A police taser on a deaf man. A policeman used a taser on a deaf man because he didn't respond to a verbal command. A man with a psychiatric disability is excluded from a meeting where his doctors and family discuss placing him in a residential program. A person with a disability develops pneumonia. He feels pressured to choose comfort care instead of treatment because his doctors feel he has suffered enough and antibiotics won't cure his disability, that disability is suffering. A woman is brought to the psychiatric emergency room where she's separated from her supporter. She gets scared and agitated because she can't communicate and is treated with physical and chemical restraint. A person with a speech impairment and a movement disorder goes to the emergency room repeatedly for a serious wound infection, but he never gets examined because the emergency room staff assume he's drunk. Next slide. So let's talk about what we can do to prevent stories like this. First, speak directly to patients. All people communicate, and it's our job to figure out how people communicate best and to support that. Observe carefully, listen, give time and a peaceful environment and tools like the visuals that you talked about earlier to help people communicate. Second, presume competence. Assume there's a good reason that people do what they do and that they have a right to be included in decisions that impact them. That means giving access to information and education, as well as support for people to make their own decisions. Third, give people tools to communicate about mistreatment. No matter how profound the disability, all people need a way to communicate when they are being mistreated. Sometimes this skill takes time, training, and creativity to teach, so start early. Repeat often. Developing the tools and the skills to communicate about mistreatment, boundaries, and choices should begin on the very first day of early intervention. Fourth, teach people to set boundaries and to protest, not to be compliant. It isn't our job to make people calm and compliant in the context of unacceptable circumstances. It's to help people maximize their potential and to participate fully. Compliance training is a setup for abuse. Teaching people that authority figures should always be obeyed is also a setup for abuse. Compliance-based behavioral treatments are often cited by self-advocates as traumatic experiences. Fifth, train families and professionals. People with disabilities aren't the only ones who need training. We need to teach others how to listen and how to respond. Communication is a two-way street. How we listen is as important to how our communication partners express themselves. Put people with disabilities in charge of developing the curriculum of teaching us how to listen. Next slide. 6, take all complaints about mistreatment seriously. Investigate them. Protect people from the accused during the process of the investigation. And protect them. This is important because people, even if you're pretty sure that nothing happened or suspect that nothing happened, it sends a message that a complaint of mistreatment is going to be taken seriously and is going to be acted upon. As you heard before, when we don't do that, no matter what the circumstances are, it teaches people that they're not to complain about mistreatment. Even if it's clear that even if it's clear that no abuse happened, following the protocol teaches people what the protocol is and that complaints of abuse lead to appropriate action. 7th, give people opportunities to try and fail. That's how we learn. This should be done when the stakes are low so that people have experience with natural consequences when the stakes are higher. They also learn to trust people who give them advice and to learn whose advice is trustworthy and whose advice is not by giving people opportunities to choose who they listen to and who they trust. 8th, get a history of the baseline function. In people with communication challenges or cognitive differences, illness can present as a change in behavior or function. If we don't know what a person's baseline is, we won't recognize that there's been a change. Ninth, respect personal boundaries. Offer assistance, but wait for a response and instructions before acting. Treat assistive devices such as wheelchairs and communication devices as personal space. Teaching people to assert boundaries, even if they need care for all of their basic activities of daily living, they still have boundaries, and learning to assert them and learning how to instruct aides how they want to be helped is protective. If you teach people that people can touch them in any way and at any time without permission that they want, that is also a setup for abuse. 10th, give people access to chosen advocates and supporters. Many people need support to communicate and to make decisions, and too often we separate people from their support when they need it the most, such as when they're in a crisis or a transition or in the hospital. This leads to errors and violations of their autonomy and misunderstandings. It's dangerous. So even if you're in a hospital, even if there's COVID-19, even if there are reasons, we need to make sure that people have access to their support and their communication support so that they can tell you what's going on, because communication is the foundation of patient care. 80% of making a diagnosis is based on the history. If we rely only on what we see, like bruises or scratches or bleeding, we're going to miss a lot of what happens. So only people with disabilities know their internal experiences. Their caregivers, even close caregivers and family members, don't know what their internal experiences are and don't know everything about what happens to them. Remember that statistically, people who abuse people with disabilities often have the same profile as family members, or may be family members, or have the same profile as your best aide. People, it's not always easy to recognize abusers, and they're often people that the person with disability and their family know and trust. Talk directly to people with disabilities. Not it's okay to get information from a supporter with permission, but when we talk directly to people with disabilities, a lot of the communication differences is not an inability to communicate, but a learned behavior, something they've learned that people don't listen to them, that they don't give them enough time to respond, that they don't respond appropriately to what they say, and so they remain quiet. People often do this, and when you give them the message by talking in a normal adult voice, because high-pitched kid voice, hi, how are you? You're so cute. That kind of voice, what it communicates is you don't take me seriously. You're not going to listen to what I say. You think I'm a child. You think somebody should be speaking for me. So people are often, when they get that voice, trying to be nice, but nice is not the same thing as respectful. And what we need is respect, because if people don't feel respected, they're not going to make the effort to communicate with that person, and we're going to miss really important information. And people who use that high-pitched kid-like voice often don't realize they're doing it. They're not doing it intentionally. They certainly don't mean to be patronizing. And so we need to check each other and check ourselves, and make sure that we get feedback, because we don't always realize we're doing it. Everyone communicates, find a way. I want to, when we're talking about supported decision making, a lot of times people pursue conservatorships because they want their loved ones to be safe and they want them to have support. But safety is about choice and control, because again, only the person knows their internal experiences and what has happened to them. And only they know, and we need to develop their ability to learn who to trust. And if we simply assign someone to make all the decisions for them, then we can actually give that person so much control over them that absolute power can be corrupting, and it can actually get in the way of that person's development, that person's ability to advocate for themselves, and that person's ability to get help from mistreatment. Supported decision making is a process where people can name a trusted supporter to help them make their own decisions. And we have a couple new legislative things in California which are supporting this. Supported decision making is now in the law in California Assembly Bill 1663. So people can develop these supported decision-making agreements and expect to have them respected in healthcare settings and in other settings. And we also have a new next of kin law, which is not specifically for people with disabilities, but if somebody arrives at the hospital and names someone to their physician who they would like to make decisions for them or to help them make decisions, they can do that, and that authority can last for the duration of their illness or for 60 days, whichever is shorter. And if someone doesn't have the capacity to name someone at the time, then the physician can look to family members or close friends who know the person and who are available to serve, and can rely upon them to make decisions for the person if they don't have the capacity to do it themselves, and if they haven't made other arrangements like an advance directive, a power of attorney, or simply naming somebody like a family member or friend or somebody that they trust. So we have tools to do better. We have strategies to do better. And now we need to do better. I'm going to turn it over now to Kecia.
This is Yasmina. Thank you, Dr. Kripke. One question that came through, and I think you should answer it right now, is how do we respectfully communicate this to healthcare providers?
We're talking about something very fundamental to the doctor-patient relationship, something very fundamental to the parent-child relationship. So this is a cultural change, and it's going to take time for people to absorb it. I think bring copies of the law, bring copies of your documents, talk about it with your doctor before there's a crisis, before you're sick. And we need to just do a lot more trainings. When you're talking about changing how people think in such a fundamental way, then people need to hear a message 7 times in 7 different contexts in order to absorb the information and be able to apply it to new situations. So they're not going to get it the first time they hear it. They're not going to get it the second time they hear it. They're going to maybe get it the 7th time they hear it. So we have to do the work. It's going to be a lot of work, and I appreciate the contribution that you're making to that here today for this audience.
Thank you so much. Leanne and Kecia?
Thank you, Dr. Kripke. We really appreciate you being with us today and sharing that. And Kecia, I don't think you had a chance yet to introduce yourself. Give everyone, if they didn't make the first webinar, a chance to hear from you. Do you want to just quickly introduce yourself?
Yes, of course. That'd be great, Leanne. Hello, everyone. My name is Kecia Weller, and I have been doing abuse prevention work since 2012 in different capacities. Like I'm a core team member for this Talk About Sexual Violence project with the National ARC, the National Center for Criminal Justice and Disabilities Center, and the Board Resource Center. I'm also part of, I'm a co-founder for the Silence Equals Violence network in California. I'm also the one of the national co-chairs for the Peer Support Network. And it is a great honor to be here with you today.
Great, Kecia. Thank you for that. And one of the things we thought would be great to do is, after hearing from that list of prevention tips that Dr. Kripke provided, is just to get your response on that, Kecia, on some of those key points that she raised from your own lived experience. And so one of the first things that we were wanting to hear from you on is, of everything that Dr. Kripke talked about, what is most important to you?
Thank you. There's two things, and I'll go over the two things right now. First, people with disabilities are human beings that deserve dignity and respect when engaging with anyone. It's very important to communicate directly with the person, not the support person, unless the person agrees and gives you permission. I know it's easy to be distracted or zoned out and not remember details, especially if there is trauma, and a well-trained support person really helps with this. Second, pursue competency when communicating with a person with a disability. Just because a person has a disability doesn't mean they are not able to understand. Their disability is what makes a person unique, and it's a lovely thing for people with disabilities to share with the world. This is talking about disability pride.
I love that, Kecia. And I just love kind of the honesty that you bring to this topic. And one of the things that I talked about earlier was, ableism, and how what causes that ableism and that those kind of attitudes is this whole thing around presuming about people, and making assumptions about people when they don't know really about that person at all. So I'm wondering if you can share if you've experienced a time where someone made assumptions about you that were wrong, and if they didn't ask for your input and really try to get information from you.
Yes, definitely, Anne. I went to the doctor to get examined for sexual assault. The doctor assumed I was not competent to tell him about my sexual assault and started asking my support staff, Emily, what happened. The doctor kept asking Emily rapid fire questions on why I was now in his office without getting input from me. I was feeling re-victimized by the doctor. I felt invisible and dehumanized because the doctor didn't think I was competent to share my own experiences. I had to redirect the doctor back to talking to me, and I told him to slow down, talk softly, and use everyday language so I could understand him. Next slide, please.
So all of those are really important points, Kecia, and I'm wondering how you share those points. I know Dr. Kripke got the same question. So now I'd like to ask you, how do you, as an activist in this area, share these lessons with peers, allies, and healthcare providers?
Yes, of course. We people with intellectual developmental disabilities, or IDD for short, who are survivors of sexual violence and trauma, we are able to make public policy recommendations, including how we are treated by the healthcare system. It is really important that people with IDD get involved. I have lived experience where I felt discriminated against in the healthcare system. I am committed to being a voice to make change so others don't have to go through what I have. I share what I have learned from my peers, allies, and healthcare providers. With my peers, I am involved with many sub-advocacy groups throughout my state and the country. I encourage conversation about ways to protect ourselves, and if anything happens, how to report and get trauma-informed care. I also share my story and what I've learned to give hope, encourage younger leaders to come forward. With my allies, these are some of the ways I'm currently involved in improving quality of care, policies, and share what I have learned as a survivor, a person with disabilities, and a national advocate. On a personal level, I am a full partner in my own healthcare. I do supportive decision making in my own healthcare. I said that journey has been like for me the mistakes in how to find a healthcare provider that listens and is interested in me as a person who has experienced pain and trauma. In addition, I was with the Talk About Sexual Violence Project. I am a core team member of the unique project that educates healthcare providers and survivors. Most importantly, we, the survivors, lead the work. That means we are partners in everything. In addition, California Silence Equals Violence Network. I am a co-founder in the 2016 of the only California network whose purpose is to increase collaboration with aging and disability agencies to reduce abuse. We share strategies and legislative priorities. We know we have to come out of our silos to really have a voice. With Foundation, I am one of the many sub-advocacy leaders that advise the board of directors of West Foundation on what healthcare proposals to fund. Our priorities are to ensure projects include people with disabilities as team members, not tokens. With healthcare, most important to me, I practice what I'm advocating for with my own healthcare team. I provide healthcare providers with resources and, when appropriate, share my story so they know how important they are to survivors. I also get involved with changing healthcare. These are recommendations for everyone. First, be your own advocate. Get your questions answered. Join networks and coalitions, not just disability coalitions. We must reach out and engage with healthcare advisory groups and networks. Bring the silent epidemic of abuse against people with disabilities into the forefront. Train healthcare providers about disability, bias, and ableism. And also, as Dr. Kripke said, as the disability model says, nothing about us without us.
Thank you so much, Kecia. There was so much information packed into that. I really appreciate every area of your life where you're really addressing these issues, and you have been such an amazing advocate to go to just state level, national level, you know, and all the work that you do is really laying the groundwork for many others to follow. So I hope that you know that. And then I wanted to, last question for you is asking, how did you learn how to speak up in healthcare settings? Because that can be really hard for anyone to do, because you feel like you don't know the right terms or you feel intimidated and things like that. So how did you learn to do that?
Yeah, definitely. Speaking up to authority figures like doctors is very hard, and it can be very intimidating because they're an authority figure. I've
Yeah.
been told that others know more about me, so I'm quiet. I was taught very young to be compliant and not talk a lot. In healthcare, that can be very dangerous. Now it's important for all people with disabilities to forget those instructions and be assertive about their own healthcare. I started telling my medical doctor I didn't understand what he was saying. I also said, tell me as a person, not the person I'm with. It took many years, but I had good healthcare mentors who told me I could stop an appointment and ask a question. I can get information in a way I understand so I can be responsible about my own body. My mentors did role play with me and checked in with me others afterwards. I have learned it's okay to have support people at appointments. It's important the person lets their support person exactly what they need. For me, I ask my support people to listen and quietly speak to me if they see I might be confused because something is difficult to understand. To conclude, I know we have a long road ahead of us, but I have seen changes, and I am encouraged by the willingness of younger advocates to speak out. Thank you.
Thank you, Kecia. I know we had some follow-up questions I'm seeing happening in the chat, but Yasmina, I'll turn it back over to you just to mention the next webinar, and then maybe we can do questions.
Certainly. Thank you. This is Yasmina again. Thank you, Kecia, Dr. Kripke, and Leanne. I am posting, our next webinar is on April 26th, and the topic is people with intellectual and developmental disability experiencing abuse, tips, tools, and strategies for providers. And there's a link to register. One question I'm going to just jump right into the questions. They keep coming, so I hope we can get to most of them. Kecia, if you assist people with intellectual and developmental disability who may struggle with self-advocating, is there any advice, Kecia, you would have to help a support staff encourage and empower the individual to feel confident enough to speak up?
Yeah, thank you for your question. I would say that having a support staff inside the medical appointments could be important for people with disabilities because I always have support staff in my medical healthcare appointments because as I had told you in my presentation, the support staff could gently nudge the person with the disability, like they could say to the person with disability, did you understand that? Or you could also before the medical appointment, you could discuss what we want to discuss. And I often prepare a piece of paper of what I want to discuss with the medical doctor. And so I shared my list with my support staff. And if I forget something on the list, then my support staff will gently, quietly talk to me, and I will say that to the doctor.
Thank you. To all presenters, any advice for intervening or supporting individuals with intellectual disability who experience and report emotional abuse or trauma? It seems like sometimes emotional abuse is not taken seriously, and it is more difficult to have these reports investigated.
I think having opportunities to participate in self-advocacy organizations can help people recognize and not internalize emotional abuse. And one of the things that I'm struck by, Kecia, in your service is that you are providing an example of how to speak out and giving people words to use and showing that it's possible for you to tell your own story in your own words. And so we need to start this very young, and start giving people opportunities to meet other people with disabilities, their elders, their leaders, to learn those skills and to not internalize negative emotional messages. What do you think, Kecia?
Yeah, thank you, Dr. Kripke. I definitely think that we should start very, very young for people with disabilities, and teaching them that they when they have negative emotions about something, be it emotional abuse or what have you, then I definitely think that it's important that they speak to a trusted member of their circle of support. And so it's a circle of support may be a family member or a staff person or others or a friend even that they could talk to. And then if it is emotional abuse, then they will be able to get some help with it.
Thank you. Another question, how could a doctor or other healthcare provider help prepare an individual for police report and dealing with the police? How can we find advocates for people when dealing with the police who are likely to have their own biases?
In San Francisco, there is a special team. And so I think having special designated people who have the training and experience to support survivors and to support people through the process of collecting evidence and getting their stories is critically important. San Francisco has that kind of service, and I'm not sure if I doubt every county has that kind of service, but that's what we should be working towards, to make sure that in every community there is someone or some organization that knows how to help survivors tell their stories. I don't think trying to make everybody an expert is realistic, but we can all be better at it. What do you think, Kecia?
Yes, definitely. I definitely think that that we one of the things a other hat I wear is that I'm on the California Department of Developmental Services Developmental Services Task Force, and with the safety net group that I'm on, we also talk about creating a safety net and creating special teams, like Dr. Kripke said, about how to respond to sexual assault survivors with disabilities. A other thing that I do is the peer support network, and the peer support network is saying peer support leaders actually are people with IDD who have been sexually assaulted, about going to APS or the police and helping the survivor before the interview and after the interview, and help them with coping strategies and stuff like that. And so there are safety nets, and there's things in place coming into place right now on a local, state, national level. And so it's very, very important that we create these teams to help survivors go through the process of talking to the police department, perhaps adult protective services, etc. Thank you.
Thank you so much. I know we're at the hour, but I just wanted to get to one last question, and that is, how do you assist an organization in changing the culture and empower individuals who are conditioned to be compliant to become independent and confident advocates with their stakeholders? Any resources or any sort of words of wisdom?
Well, I know at UCSF, students have been change makers, and people with disabilities themselves have been change makers. So I think you get that kind of organizational culture shift when people demand it. And it helps to have leadership that is supportive of wanting to make that change. But the work that we've done to have people with disabilities fully included in our communities means that there are more people who have friends and family and people that they know well who have disabilities, and they're more comfortable with recognizing the power dynamics and the problems. I also think when we talk about disability in terms of civil rights and in terms of and in terms of diversity and the value of people with disabilities, then that helps people make that change. What do you think, Kecia?
Yes, definitely. Because as Dr. Kripke said, it's the people with disabilities first that help to create the cultural change in organizations. Like what she does at the University of California in San Francisco. I have also experienced that at UCLA in Los Angeles, California. And it's a lot of the students in at UCLA plus people with disabilities are creating change in their different organizations, and it's very important for everyone. So because when we step for when people with disabilities and other people in marginalized communities stand up for their rights, we say yes, we can definitely do it. And with more and more people speaking up for their rights, the culture is naturally going to change.
Thank you. Thank you so much for all of you, the attendees who have actually stuck for 3 extra minutes. I wanted to thank again Kecia, Dr. Kripke, and Leanne. Hopefully we will see most of you or many of you on April 26th. Have a great day, the rest of you, and we will share the recording, all of the resources and the PowerPoint deck and everything else, and you will be emailed once we put that in archive. Thank you so much. You can always contact us directly, and I can put you in touch with all of the presenters here. Thank you so much, and have a great rest of the day. Bye.
Thank you.
Thank you.